huge number of patients getting COVID positive after vaccination. So the vaccine, post-vaccination COVID positivity rate is quite significant. That's what we are noting. And that's the matter of discussion. If you have any such experience in literature or in your country, we would like to discuss. So I would like to discuss some basic slides. So my first concern is that in India, what we are facing, which maybe you may be facing this in many neighboring countries. So what we are facing in India is a very high vaccination rate with a very high infection rate. The positivity rate in at least 8 states is more than 8%. So there is a high infection rate, and simultaneously we have a very high vaccination rate, even largest vaccination rate in the country, something like more than 3 million vaccinations in a day. And our infection rate is also almost 150,000 per day. So can this be a matter of concern? I'm talking about, can there be an interaction between high vaccination rate and high infection rate? Same situation was seen in Israel. So they intensified their vaccine rate and they controlled the infection. Michigan is facing the same phase. The vaccination rate is more than 30%, but their infection rate has not started falling down. It is still rising, rising, and rising. In India, we are getting a significant number of post-vaccine COVID positivity. So the question is high vaccine, high infection, and high post-vaccine cases. So vaccine failure is inevitable because the efficacy of AstraZeneca is only 70%. What does it mean? Pfizer and Moderna says out of 100 vaccinated, only 5 will get COVID-19. So with AstraZeneca or with Covishield in India, we expect 30% to become COVID positive after they are vaccinated. But all these companies says, we are giving you some amount of antibodies. Now here is a question. So therefore 30% will get COVID-19. And ideally it should be non-pulmonary, systemic reactions. And if it is pulmonary, it should be mild. But I have 3 cases to whom we have lost, who developed COVID after the first vaccine, and we even lost them. There are a number of cases we lost them. One of the mechanisms we are putting forward is they have not yet formed antibodies. But I'm talking about those cases after 2 weeks of first vaccine. Can partial antibodies or non-neutralizing antibodies may be a concern? And another thing we are trying to find out is, so when there is a post-vaccine COVID, is it a wild virus strain or a new strain? Or it is a newer strain? There is a new strain developing because of the war between the vaccine and the cases. These are questions. If it is a reinfection, in India, we have 2 types of reinfection going, the UK strain or the double mutation. If that's so we have data available that UK strain cannot cause AstraZeneca vaccine failure. The only way you can get a vaccine failure means post-vaccine COVID. It has to be South African strain or a Brazil strain or so-called double mutation, which is between Brazil and South Africa in India. That may be the one which is causing post-vaccine reinfections. Now, day before yesterday, we got 40 doctors in one of the medical college in Uttar Pradesh who, after the second dose of vaccine, became positive. Day before yesterday, we had 37 cases in a hospital in Delhi became positive. Then we have another 20 to 25 doctors at All India Institute of Medical Sciences who became positive. And another set of AIMS Bhopal, where around 13 to 23 doctors have become positive. So in the last 72 hours, we have approximately 100 doctors at 4 different hospitals becoming positive after the second dose and after the 2 weeks. All of them have received Covishield, which is AstraZeneca vaccine. So this is now becoming a matter of concern. Approximately 4 different settings, 100 doctors becoming positive. Obviously, 95% of them are milder infections. Why it is happening? What may be the reason? It cannot be a UK strain. The reason being, if it was a UK strain, it cannot form a super spreader and a cluster, and it cannot cause a vaccine failure. And if it is a new strain, like a double mutation, then we have, these are the 4 super spreading events. That means super spreading events are happening. My question is, can a super spreading event be precipitated by a vaccine? That means if you give a vaccine and that vaccine comes into 30% category, can it precipitate a super spreading event? Now we are getting a large number of patients today in the second peak, which are showing classical clinical symptoms, but negative RT-PCR. One of the reason can be, which I will discuss. One is ICMR guidelines. They have redefined CT cutoff from 40 to 35. So all those cases who were CT 35 to 40 will now be labeled negative, though actually they are positive. The second thing is in children where it is causing more infections, the viral load may be low. So therefore, the virus may disappear earlier than 7 days and you are getting false negative. But the most important thing we are getting in India is called E-gene target failure. In the morning also, I got a doctor calling up from our Northeast that all my patients are classical COVID and we are admitting their RT-PCR is negative. We are sending them in a non-COVID ward and they are dying. And they are also spreading the disease to others. These are called as a specific phenomena called E-gene target failure. In UK, we have heard S-gene target failure. This is peculiar to India. E-gene target failure means if you screen this test, E will be negative. And if E is negative, your computer automatically will label it as negative. That's a computer command. But if you have E-gene failure, RDRP positive, that's positive. So these are the cases we are getting. So 15 patients I called up yesterday who developed COVID-19 after the first dose of vaccine. 14 out of 15 had a CT threshold value of 30. That means in these cases, they were all mild COVID-19. Is it a disease enhancement? Okay. Is this vaccine causing a disease enhancement? If it was causing a disease enhancement, we should have seen these cases all over the Europe. We are not getting them. We are getting heparin-induced, heparin-like situation, autoantibodies we are getting, we are clot formations we are getting, but that is after 4 days. The new data shows that majority of the complications in India are in the first 3 days. These are inflammatory conditions and not a thrombotic conditions. So disease enhancement is unlikely. Most of these people are not developing COVID pneumonia. Can inadequate antibodies be the answer? What does it mean? If you are giving vaccine, patients are developing non or partially neutralizing antibodies in 30% of the cases. And if they develop corona, it can precipitate non-pulmonary systemic inflammation, means there is TNF alpha is not involved, and they all cause non-pulmonary systemic inflammation, very high grade fever, very high CRP. Where can it happen? So if you give a vaccine post-COVID, or if a patient's original antibodies are fading, or after first vaccine you get COVID, or after second vaccine you get COVID, if your level of antibodies are inadequate, it may be precipitating a peculiar systemic inflammation with the new corona infection. Should we give vaccine to post-COVID? I am debating myself that all those patients who are post-COVID with good amount of antibodies, if we are giving them vaccine and if that vaccine produce inadequate response, they are developing systemic inflammation. My last question is, whenever there is a high virus transmission in the society, mutations are known to occur. And whenever there is a high vaccine rate in the society, mutations are known to occur. In India, we are seeing both. High virus turnover, that means increase infection rate, also increase vaccine rate. It is going to put pressure on the virus. Do we think that India is going to have multiple mutations occurring because of these two pressures? And systemic inflammation we are defining as high CRP, high fever with positive antibodies. I wanted to put this for discussion because this is the situation we are facing in India. 100 doctors becoming positive after second dose of vaccine. No international media is talking about it as yet. WHO hasn't talked about it, but we know from very clear-cut reports that 4 super spreading events, 2 doses of vaccine, 2 weeks after 2 doses of AstraZeneca, specifically healthcare workers becoming positive. 100 is only doctors. The number of healthcare workers may cross 200. Dr. Chong. Dr. Chong.
Mr. President, in the meantime, yes. Can I ask?
Yes, please.
I've just joined, but I have heard the last few comments of you. I just want to know that as myself have taken the both the dose of coronavirus, which is Sinopharm in Pakistan. So as you mentioned that 200 health workers in India having this systemic inflammation after having the second dose of AstraZeneca. So do you think that this is happening to all the vaccines, or this is only the particularly you are talking about the AstraZeneca?
See, the observation is all of them have received Covishield. We are only giving you examples. All of them have received Covishield.
Okay.
Which is AstraZeneca.
Okay. So my second question is, what as a national association, what we will do? Should we advise people don't have a vaccine or don't have a?
No. We are
what we do
at this moment. Advisory job is to come from the WHO. Our job is to debate. Are we missing something? Our job is to debate. Are we missing something? Our job is to guide the ministries and the WHOs with our anecdotal examples. And we as a medical association will be the first to come back to anecdotal examples. So anecdotal examples are that 4 centers in India have developed infection after second week. Now, let us go one by one. Is it expected? The answer is yes, because AstraZeneca says we are only 70% effective. Now, your Sinopharm also is 70% effective. Therefore, we expect 30% of all those people who have received Sinopharm to develop COVID. But this COVID should be mild. We are seeing mild COVID in majority of them. It should be mild. It should have a CT value which is very high. But we are also getting a peculiar situation of patients where after the first vaccine, they are getting, see, of late, we have seen reinfection has increased. Of late, we have seen that after first vaccine, many people have died because of COVID, which shouldn't have happened. At this moment, we are presuming that antibodies may not have formed. Therefore, they have developed severe pneumonia. But my question today is a theoretical question. Can inadequate antibodies precipitate, can inadequate antibodies be the cause of a multi-system inflammatory disease like situation of children, which we are getting after vaccination? That's my question. But at this moment, there is no panic because all those cases, because all of you are going to develop, 30% of all of us are going to develop COVID, but that COVID should be mild. And that's what they have been claiming. But I am talking about is, are we missing something in terms of some of these cases who are developing systemic inflammation? Some of them are developing systemic inflammation without pulmonary involvement. And if they get it, I am not worried. But if pulmonary involvement comes, what can be the reason? So I don't think so there is anything to panic. There is anything at this moment. These are anecdotal examples, but we definitely are getting post first vaccine, we are getting patients who are getting infected. Dr. Mathanda Pillai, what is your experience in your hospital?
Yeah, it's a very good critical analysis of the situation. But I feel that this is in line with what has been already declared by ICMR and the scientists, that the vaccine gives only 60 to 70% protection. And that is what we are seeing. And that too, after the most of the infections have been after the first dose. And it has to be 2 weeks after the second dose. So before 2 weeks, they are likely to get infection. That is one aspect. Second is, of course, although in India we have given vaccine to a large number of people, the percentage of people vaccinated definitely is not very high. So we are yet to achieve a herd immunity in our country, which will take a long time and more vaccine has to be there before that happens. Then regarding the UK variant, in Punjab, 80% of the samples showed it is the UK variant. Whatever study, animal study has been done there, show that UK variant is not a super spreader, and even the infection is not serious, more serious than the other strains. Regarding the double mutant, we still don't have any scientific data whether it is a super spreader or the infection can be more serious. But one thing is very clear, that after immunization, even after first dose or second dose or whatever, the infections have been milder and the mortality in that category definitely has been much less. So whatever is happening is in line with what has been mentioned about the protection that each vaccine gives to the people.
So what I wanted to add to Dr. Pillai is, Number one is these 4 cases of clusters, which has happened in 4 different places in medical colleges, come hospitals, cannot be answered by 30% failure, because that cannot happen in a cluster. So there was a super spreading event in those locations. So this cannot be the UK virus. Something else has to explain this. 4 locations, approximately 40 doctors in one place, 37 in one place, 25, 23 doctors in one place. Cluster of cases occurring in 72 hours cannot be explained by normal vaccine failure. Vaccine failure cannot come in one hospital only. It will be a generalized phenomena. So there is something what we are missing in this particular as an explanation. Number two is, my concern is that these people, 100 doctors, they may not get a mild infection, but they will spread it to others unless we say that they are non-spreader. If they were non-spreader, they would not have infected each other. So up till now, we were thinking that post-COVID, you are a non-spreader. If you develop post-vaccine, if you develop a COVID, you are a non-spreader, has been our thinking. But this is disapproved by these 4 examples where we have seen that they are not only spreader, they are a super spreader. And if they spread infection to the community is not going to get a mild disease. So these doctors may have got a mild disease. So my concern is, why a super spreading event? That cannot be explained by why a super spreading event in India at 4 different locations within the past 1 week, and specifically to healthcare workers becoming positive, most of them having mild disease, except 5 of them have been admitted. I don't know the details. Why should a super spreading event, why should a person develop COVID after 2 weeks? And why should he become a spreader? And why should he become a super spreader? That's what my concern is. So I agree with you. I'm only trying to say is, because if we can catch the reason here, because Covishield now is going to more than 80 countries. Either what is the reason, we need to find out.
You are absolutely right. And you have critically analyzed that situation. But here is an opportunity for us, because certain clusters of infection has happened. So it is better that we go into more study regarding variants and mutations from those samples, which will definitely give us more information. But another fact which definitely we'll have to consider is that the COVID precautions, like wearing the mask, hand sanitation, keeping distance. Nowadays, people have taken it very lightly, and there is a lot of break in following these basic precautions, which in spite of taking the vaccine, you are supposed to follow it. So that area again needs a lot of emphasis, and we have to advise the government that it has to be followed.
Trying to find out the reason, if we can find. I agree with you. Can we find out the reasons? Is it possible to find out the reasons? Anybody else? South Africa.
Hi, morning, KK and everyone here. I just would try, I'll just give you a brief thinking about what we did here in South Africa. And you all know that we actually got the AstraZeneca, and the dilemma that we find ourselves in when it was clear that it's not positive, or it don't give you neutralizing antibodies against our second strain. So we then decided not to take that, and the whole drama around it. So we are on Johnson & Johnson vaccines, and what we have so far, we have around about 300,000 doctors and healthcare workers vaccinated. That's unfortunately our total sum of vaccinations in the country. But on the Johnson & Johnson vaccines, we are very, very clear that immunity only starts after about 28 days after the dosage. Yes, you can start thinking about 14 days, but it's 28 days. So it means that during those first 28 days, you can still get COVID-19. We are busy with excuse me, surveillance around that, but that's what the data is showing us. Then we are, our scientists are working very hard in the background on genome testing, because we are seeing some people coming in from other African countries, and we have now seen that the strain that was in Uganda coming from Tanzania, we are also keeping a very close eye on that. And it is true that if you vaccinate your people, where you would have been 100 people being admitted for serious adverse or for COVID-19, after vaccination, it's supposed to come down to about 15. So we are very clear in South Africa that we are vaccinating to get you out of the hospital. At this stage, we're not even saying that we are trying to stop super spreading events, or we are trying to stop it, but not via the vaccination, because we're not sure exactly what KK asked. Whether if you had been vaccinated, can you still spread? We're not sure about that. There's not enough data, and I think this is the dilemma that we are all facing, is the data is not there. It's not long-term data that we can fall back on. Most of these are trial phase 3B trials, and then we put it into the, start vaccinating the community. And that is what it is. We are going to learn as we carry on. And Keika, you are right. There's something wrong. So I would say genome testing, double check what is happening there. I also brought up the fact that I don't think the PCR testing is doing justice currently. And there's a lot of, PCR, it is it's the test itself, it's the logistics around it. And then again, what are they testing on that? So when you said about the E gene and the spike, if there's another type of mutation, they're going to miss it on a normal PCR. Thank you.
I just want to add again what she spoke. Now, what I mean to say is we don't need an evidence. KGMU, 40 doctors, 6 staff, all vaccinated, double vaccinated, 2 weeks after second vaccination over, in a matter of 48 hours becomes positive. All resident doctors, they meet each other. Gangaram Hospital, 37 doctors positive. All India Institute of Medical Sciences, 30 doctors becomes positive. Bhopal, AIMS, 53 mixed people, not only doctors, become positive. All becoming positive were in the last 72 hours. So you can imagine here, how can we say that after vaccine, if you get COVID, you are not spreading? I think I don't need an evidence here. These are 4 super spreading events, not spreading, it's a super spreading event. There is no answer. There is no way one person who is not vaccinated can go and infect 37 doctors. No, it's not possible. They have to cause the infection from each other. So I am for sure very clear that that theory that after vaccination, you are a non-spreader is not correct. I am discussing it other way around. Can vaccination, if you develop inadequate antibodies, makes you a super spreader? I'm going other way around. I'm putting it a theoretical question. Can after vaccine, if you do not develop antibodies, can you become a super spreader? That's my theoretical question. Anybody?
Mr. President, I don't know. Maybe I missed. I would like to know that if anybody have the post-COVID tested antibodies, and that antibody shows a lot of antibodies in his body, and after even then he has taken the vaccine. So what will be his conditions?
So I will give you an example. Dr. Puri, who is the Vice Chancellor of KGMU in Lucknow.
Okay.
In August last year, developed COVID positive.
Right.
He received his first vaccine in February. He received his second vaccine in March 25th. Okay. And now
Okay.
he has become infected again. How do I explain?
Oh,
He has one natural infection, then first
uh-huh.
Covishield, second Covishield. Now he has got reinfected after the second vaccine.
Yeah.
He is now positive. How do I explain? I'm not been able to find the answer. These are the cases which have to. These are the cases. If we find the answer, will help us in finding answers for many unanswered questions.
Now
Unique
this
case,
is
four times, two natural infections and two vaccines. How can we explain? I'm not been able to.
now
The only way I can explain is that if you do not develop full antibodies, something like we used to call them as disease enhancement, something what we used to call them in dengue disease enhancement, something we are missing. In those cases who are not developing full antibodies, maybe we require a third dose, like rabies, where you require multiple doses. Maybe if your efficacy is 70%, two doses may not be sufficient, because if you are producing inadequate antibodies, that may be harming you. So I am basically putting in a case that two doses of vaccine may not be adequate if you develop inadequate antibodies. That's a theoretical possibility I am putting forward. I'm trying to find an answer to an unanswered situation. We cannot ignore one doctor getting twice infection and twice vaccination. We cannot ignore it. We don't have to find an answer. We have to think laterally and try to see how can we answer that situation.
Mr. KK, actually, I have the same issue. I have as you know, the both vaccine have been given. I have received both vaccines. In first vaccine, I had a little symptom like lethargic and pain in my back. I mean, between the scapula, and sometimes feel like a feverish burning of the eyes, but not so much disturbing. And it lasts at least 3 days. And same here. After the second vaccine I have received, the same thing I feel like that. Today is my third day after the vaccine. I'm worried that most of our healthcare workers do not have any symptom after having first vaccine or second vaccine, do not have. And a few of them have informed me that I have tested myself just to see the antibodies. They said that I receive so much antibodies. It's sufficient. It's very good. So in this scenario, what people is still asking us, Dr. Saab, what we will do? Either we vaccinate ourselves or not. What we do?
The answer is
to vaccinate.
Vaccination. You have no choice at the moment.
Yes.
You have no choice. What I am basically discussing is, if your efficacy of a vaccine is lower, 60 or 70%, so specifically Sinopharm, which is a killed vaccine, in a killed vaccine, are 2 doses sufficient? That's what I'm talking about. Now, if we see the Covishield also, which is a AstraZeneca vaccine, that also contains only the gene, and that to cut gene. It is not a complete gene like in mRNA vaccine. I don't know. I mean, it is also a convert type of a gene. Are they producing some sort of inadequate antibodies? And if they produce some degree of inadequate antibodies, can it produce certain reactions in me? That's the theoretical question I'm putting forward with examples. You cannot explain 4 super spreading events in India without answering, because up till now we used to say, if you develop COVID vaccine, you will not die, you will not develop pneumonia, you may not develop severe pneumonia, and you may not be a super spreader. Now, these four cases have, nobody is talking about it in international media because this is peculiar to India. Unless you start, and I am worrying because Pakistan, Bangladesh, you may start, if you start getting Covishield, or you may start seeing these types of cases. Is it specific to Covishield manufacturing? Is it because we are not seeing these responses in Europe? But I have to put it into observation for discussion.
Dr. Tiagaro,
Yes.
can I just lead to a separate side actually? This is actually Dr. Angelique Coates is here, so I'm getting more interest because here in Bangladesh, disease is spreading heavily, and actually the number of deaths also are increasing. Actually, it's a very worrying situation here, and you know, like India is spreading like in Bangladesh also, and we are knowing it that probably most of the viruses here prevailing is a South African variant. So we are worried about, because we knew from the Dr. Angelique and also from the literature also, this they have stopped vaccinating the Covishield there because it wasn't working there. And now the Bangladesh is having the Covishield, and almost 3% of the population has been vaccinated, more than 5 million. So this is a worrying situation because we do not know actually if it is South African variant is it's a true story. Then definitely we are worrying actually whether this Covishield vaccine is going to work here or not. So can I just get an answer from Dr. Angelique? How you approved there that this vaccine doesn't work and you have gone for the Johnson & Johnson?
Thank you. Let me just so we haven't proven our SAPRA and the advisory committee on vaccines are quite strict with what the requirements of the vaccine should be, and any vaccine that is not showing to be effective against the second variant, we cannot take that, because that is the predominantly the one that is spreading in our country, and we suspected that it would go to other countries, and there I would have cautioned other countries' scientists to take that possibility into account. So in South Africa, there's only currently 3 vaccines that would be effective. Unfortunately, 2 of them are very difficult and expensive, but it is the Johnson & Johnson, Pfizer vaccine. Although Pfizer vaccine's neutralization, there's something about the neutralization, but antibodies that was a bit querying regarding the second variant. But the efficacy is so good that actually didn't make it's not going to make a difference on the on the efficacy of whether you should not use Pfizer. So Pfizer is a good vaccine in our eyes, and then Moderna. That's the only 3 vaccines currently that SAPRA has looked at all the data, and the MAC committee looked at the data. The problem with the others, and the Sputnik and the other one from India, is that the data is not sufficient at this stage. There's still some data lacking. And once if we get all the data, we will reevaluate. But and I think maybe that's something as well that your countries needs to look at, or your National Department of Health needs to look at, is the efficacy against all the strains that are very predominant going around the world. But for now, if you had Pfizer's, you should be safe against the South African variant. Unfortunately, our Pfizer vaccines will only be arriving within the next 2 weeks. I suspect from my side in South Africa, we're going to have quite a lot of logistical problems in getting that out, looking at the way South Africa is. And I presume that it might be the same in India. I'm not sure whether India's got Pfizer, but for now, that's the 3 vaccines that will give us the best protection against our South African variant. Thanks.
Thank you. What about India? What about India actually because of this variant, South African variant is prevailing? Dr. KK, your
India, majority of the cases are UK variant. The South African and Brazil variants in India reported so far are very low. Majority of them are the UK variant. But that is what is evident. But unless you test many more cases, we may be missing South African variant. Now, this 4 super spreading events cannot come from the UK variant. So that tells us something fishy is going on. Is it the South African variant, Brazilian variant, or a virus seen in South Africa, or a virus seen in Brazil, or it is a virus seen in India, which is causing these problems?
KK, if I can add on, the double mutant, we had to have more studies on how it spreads and all. And that is one area which definitely we have to concentrate. Second thing on the question of not having enough of antibodies, we had to have a double plan. One is, of course, to consider giving a third dose of the vaccine. And second, of course, these sort of clusters which are developed, further deep study on the genetic variants and things like that has to happen. And more than that, it is well known that mutations can happen. And even with the influenza vaccine, every year you go on changing it because more mutants come. So the same process definitely has to be done with COVID also. We had to think of bringing out another vaccine which will cover the variants and even the mutants. And that work on that definitely has to start. Meanwhile, third dose, whether it is feasible, has to be considered.
So the idea of today's meeting was, are we also finding these things in other countries? Because our country, because we will write to the government, IMA will also write to the government. But the question comes is, when we are in a CMMAO platform, A, to inform what's happening, B, are we also seeing this phenomena in other countries who are receiving Covishield? The problem comes in with only Covishield. It's not coming with Covaxin, which is equivalent to Sinopharm. Now remember, now the government, even the European regulators and WHO has clearly linked the clotting formation. And there also we should know very clearly, clotting means a complication occurring after 4th day. After 4th day of vaccine, if your platelet count reduces more than 30%, and if you have symptoms suggestive of venous thrombosis somewhere, and what we are getting is high D dimer because we are going for a D dimer. So if your D dimer is increasing, your platelet count is reducing, immediately put them on anticoagulation before they end up into a clot formation. I have seen at least 6 or 7 such cases where we have seen clinically high D dimer and low platelet count, and we have corrected them with timely rivaroxaban. But today's talk basically is there that those 30% of the people in Covishield, 5% in Moderna and Pfizer, and around 40% in Sinopharm and in Covaxin, if they do not develop full antibodies, if they develop partial antibodies, that can be of a consequence. I have no answer. I will be putting it for debate to all my country experts today and tomorrow. But I wanted to put it to the knowledge of the people that this is a strange phenomena we are observing. Covishield is also going to neighboring countries. Just observe. The matter is not of serious because we are not seeing the deaths because of this. But maybe collectively we find an answer for that.
Dr. Agarwal, regarding the clot formation, actually, EMA just say that yes, it's to be noted as a or is to be listed as an adverse event, a most rare event. So, but they are claiming that it's very effective.
No, we are not talking about it. We are saying is, they are saying it as a rare event. We are saying it is preventable event. We are going further. We are saying it is a preventable event. If you can pick up, if you grow a platelet count in susceptible, they are talking about women less than 60 years. They all are on hormones. So if you suspect a woman who can be having a event, why not protect it and prevent it by aspirin or by a anticoagulation? That's what we are talking about. They are calling it as a rare event. We are saying it is preventable rare event. So you can, it is diagnosable rare event. It is predictable rare event. It is treatable rare event.
When should it start? When should it start actually? This.
All my patients, I mean, today I'm going to the extent of even debating over all high-risk patients should be put on aspirin during this COVID era. I'm talking about universal aspirin for high-risk individuals during the COVID era, so that they don't end up into this complication if they get a vaccine or if they develop a disease. I'm talking about universal aspirin. Wherever there is a doubt, debate, should I give it or not give it? I'm talking about debate. I'm not talking about healthy people, high risk, susceptible people. If you have a debate, should I give it or not? You say, I don't want to give it. I say, give it in the COVID era.
But the actually internists, they are doing that. If you give aspirin in low doses continuously to everybody, there is a chance of this hemorrhage, brain hemorrhage. Is it correct?
Very rare. Again, very rare. Therefore, I say high risk, susceptible with no contraindication. Alvin. Alvin, then Dr. Akhtar.
Morning.
Adiki, Apurva Adiki, also I think from South Africa is there. Yes, Dr. Alvin.
President, in Hong Kong, our situation is that the community has single-digit or even zero cases now. There are imported cases, about a dozen of import cases coming back from UK or from Philippines and also from India or Pakistan. So, one big issue now is because in Hong Kong, many citizens, residents have employed sick helpers. In the Philippines, with UK variant or the spring Hong Kong, whether there be a fifth wave of these mutated genes, and then the list of the
If it's not audible, then I can. No, Elvin, you are not audible. Can I ask Apurva Aditi to speak? Apurva Aditi. I think there are no more speakers. So I will request Angelique to kindly sum up today's meeting. Angelique, can you sum up today's meeting? Because Dr. Chong is not here. Can you sum up today's meeting, Angelique, if you are still there?
Sorry, I was just struggling to unmute myself. So,
so see,
I listen
Angelique,
to
Angelique, whenever you got muted, it means your mic has gone for a RT-PCR test. So whenever the RT-PCR test becomes negative, the mic automatically gets unmuted. So don't get upset. Your mic had gone for a RT-PCR test.
Okay, and it comes back positive because it's open now. Thank you. Listening to today, I think there's serious questions. I do agree with Dr. KK that these questions that's unanswered, we are missing something. I think we are missing more than something. Only time will tell us. We need to go back to the drawing board, and the scientists in our countries needs to relook, and we need to, although Dr. KK said it's anecdotal, we cannot just dismiss anecdotal cases. I know scientists love to dismiss anecdotal cases as anecdotal, but this is, for me, it's not anecdotal. It's real life experience that we are seeing. And there are serious questions around AstraZeneca in India.